Good evening and welcome to AMDA COVID Grand Rounds, Pearls from Your Colleagues, an ongoing peer discussion on COVID-19 in the post-acute and long-term care space. I'm Sabine von Price-Friedman from the Washington State AMDA chapter, your host. We want to make this a very interactive discussion, so it would be great if you could use the chat function. Actually, I love the chat function. All of us always learn, and from the questions and also the answers that you may have, so that it really extends beyond just us, the panelists. When this pandemic started, what seems like eons ago in March, we didn't have much time to think. But most of us hoped that the pandemic would be under better control now. Instead, we're finding ourselves among rising COVID cases in the country and evidence that correlated rising community infection rates with risks to outbreaks in our facilities. Those of you who attended our last Grand Rounds 2 weeks ago heard our excellent speakers present new evidence on infectivity and the lingering effect of COVID-19. Just last week, a paper in JAMA Cardiology described evidence of perimyocarditis in a large percentage of COVID-19 patients 2 to 3 months after their diagnosis. It goes without saying that none of these studies, of course, look at our patient population, which is by last estimate accounting for up to 60% of COVID deaths in the United States. This is a good time to debrief, look at evidence, changing regulations, and a body of experience to discuss the state of the art of COVID-19 in post-acute and long-term care now. What have we learned since March about how to best prevent and treat COVID-19? What do we wish we had known in March and April? And what do we know now, and how did it change our approaches? How comfortable do we feel with a new time-based precaution relaxation from CDC? What are our medical strategies for COVID-19 patients now? Have we changed anything in palliative care treatment of COVID patients? Here to discuss these topics, we are fortunate to have two highly regarded experienced medical directors. Dr. Steven Buslewicz. Hello, he is a partner in 20 geriatric, in a 20-person geriatric practice, so a pretty big geriatric practice. They take care of many facilities in the Buffalo, New York region, and he himself is medical director in 5 SNFs and assisted living. Also, of course, if you know anything about IT, Steven is the founder of Patient Pattern. I'm not attempting to understand all that Patient Pattern does. If you have a question about that, you ask them directly. And we're also really pleased to have Dr. Ellen Kehr as a panelist. She's Associate Professor of Clinical Medicine at Indiana University School of Medicine and a proud graduate of the Futures program. So that is particularly exciting to see. Her research passions are dementia care across the continuum and high quality advanced care planning in post-acute and long-term care. Her COVID-19 experience includes managing an outbreak in a facility that was fairly large, and it has inspired her to look further at innovative approaches in advanced care planning. So, as we like to do, we're going to start out with a poll, and the poll is going to be a little different. This is going to be an open-ended poll. So I'm not going to give you choice answers, but what I'd like you to do is to use the chat function to put your answers in. And so you find the chat function, you look at participants, and you figure out how to find the chat function. It's right there on the bottom of your screen, most likely. So I'm going to put this question forward. What was your most important, and then you put the answer in the chat, and then we take it from there and pick up the discussion from there. What was your most important change to the approach of COVID-19 in your facilities or with your patients since the beginning of the outbreak? So what's the most important change, advance, that you have experienced, or setback as it may, in treating COVID-19 in your long-term care and post-acute care communities. So I'm going to start monitoring the chat function. Please say something, or else we'll have to do it, which we will do just fine. So cohorting. Yeah, we can talk about cohorting. I think particularly cohorting well or doing it right and not cohorting the wrong people. Surveillance testing, I think creating hot zones, anticoagulation, it's all fantastic topics really. Telehealth, no visitation. Using recommended treatment modalities, so we'll be talking about that now. Time-based criteria, appropriate PPE, yeah, insofar we have it. Somebody said recognizing we have AGP in the NH. Can somebody enlighten me what AGP is?
Is that advanced geriatric provider? Is that like an APP or NP or PA?
That's almost what it sounds like.
Utilizing that workforce maybe?
Yeah.
As great practice extenders?
Keeping up with all the executive orders. All right, I think we got a lot. Care coordination with a local hospital. Okay, that's maybe what that was referring to. Okay, I think you have done a great job at highlighting many of the changes and some of them for the good that have taken place. So let's and feel free to refer to those topics that were brought up. I'd like to start with you, Dr. Kerr. What did Ellen, what did you learn from your challenging outbreak? What do you wish you had known? And then how would that have translated into different practice?
Yeah, absolutely. So I will say initially, back in March, we were looking for impressive fever and impressive respiratory symptoms. And as each day passed, we had ill residents with low-grade temps, fatigue, anorexia, and we learned through the medical literature that there's a whole host of symptoms that can be caused by COVID-19. So I think that we are broadening our differential, and so we now have the knowledge that we need to recognize this as possible COVID-19 and that we need to test, and we need to test immediately. And thankfully, we are at a different place with our testing. So I think that has been a great clinical change for me. So when I had my outbreak, which was late March to early May, we were using the test-based strategy to discontinue precautions because we thought that that was best practices. But unfortunately, it created a lot of morbidity and prolonged isolation. So we had residents in isolation for 30 days, 50 days, a lot of morbidity with weight loss and debility, fatigue, and there was a lot of psychosocial distress with the families and the residents. So they would get a negative test and then they'd get an inconclusive and a positive. So some residents were tested 4 to 6 times. That doesn't feel good. That's not a good use of resources, and we're creating morbidity. So I'm really excited to discuss with everybody the test-based or the time-based.
Are you using the time-based strategy now? We'll talk about that in a little while, but
yes.
Are you using it now?
So I have had 0 cases since this recommendation, but so my approach would be yes, at the 10-day mark to physically evaluate them, review the fever criteria, and review comorbidities and medications and say, yes, in fact, they are not immunosuppressed. And I would do that.
Okay, all right. So Dr. Buslovich, Stephen, What's your medical strategy for COVID-19 patients now, as opposed to maybe earlier in the year?
Sure, Sabine. So, I've had, I would say, great success in my nursing home facilities in terms of outcomes. We've actually had no COVID-related mortality, and we did have outbreaks. I did have mortality in my assisted living, where the whole facility essentially went on COVID fire. And we quickly realized the limitations of managing outbreak in assisted living versus a nursing facility. And so what I did there that I think worked, and I probably would still continue to do again, is my clinical trial N of 1 was essentially to provide every patient on the unit where we had COVID patients with high dose vitamin C every day as sort of my Hail Mary anti-inflammatory approach. And then provide them with a structured hydration protocol where a nurse or an aide would provide fluids, essentially make sure they're drinking every 4 hours. Just give them a cup, make sure we have a structured systematic approach to hydration. And then we actually gave them ice cream. And so we gave every resident ice cream frequently. And the reason for that wasn't a particular flavor choice or preference, but if you think about what happens with patients who develop COVID is they lose their sense of smell and taste. And so as dementia patients, obviously, they are already limited in their taste preference because the only sensation they typically retain are textures and temperatures. And so ice cream has both that they enjoy. And so the idea is really just to get the calories into them and essentially keep them hydrated. And it worked.
I love it. Ice cream as prescription. Yeah.
And you know what? And you know what? We had.
That's the downside. Nowhere.
Yeah. And we had about 15 out of 100 patients go to the hospital. About only 5 died. Many have returned. Some ended up in skilled afterwards. But I think relative to, what happens when the facility lights up, I think the outcome is relatively very good. And it was completely attributed to dedicated nursing, pushing fluids, keeping these patients hydrated, and, giving some calories to them to essentially, keep them from declining. I think, some of the other medication changes that we made was to reduce or almost eliminate nebulizer treatment early, reduce polypharmacy across the board. We use this as an opportunity to really reduce risk. So, any stressor that we thought, could potentially be detrimental to patients, we reduced, and we basically kept it to the core medications that we thought were relevant. It also substantially helped the nursing burden when we had understaffing and the med passes were a little bit shorter, more manageable. And I think patients probably benefited from just less polypharmacy as well.
This was one of the big learning experiences for me, that, less is more. I guess we kind of know that, but we kind of sort of limping along with a little bit de-prescribing here, a little bit de-prescribing there. And I am now more than ever a believer in de-prescribing. And I think what you're saying is the aggressive supportive care is something that my first outbreak was on March 3rd, I think, or 2nd. I mean, it was very early. That we didn't realize in the beginning. Also, we didn't know about the anosmia and the sense of taste that was gone in the beginning. So we didn't know how important hydration was. But then we noticed that if we gave IV fluids, and that's of course, or Clysis is something that we have done regularly too, that how perked up patients actually became, as opposed to really dwindles fairly quickly and decreased mental status fairly quickly. So really you can do something with supportive care and fairly low tech I love the prescribed ice cream. I want that when I have COVID.
Vanilla ice cream all
Hopefully
day
never
long.
forget.
Just change the flavor daily. I think it.
Yeah, I think that's true. You got to don't stick only with one boring thing. I'm intrigued by the vitamin C. What's your evidence behind that?
The evidence is unsupported, I think, but it's essentially a low risk initiative. So I think risk is low, and ultimately, if it helps, great. Probably won't hurt them. But I didn't feel comfortable with the hydrochloroquine approach. I didn't initiate that. I'm still mixed on the prednisone strategy in this population. Especially.
Can we talk about that? Let's talk a little bit about prednisone, because I think it came in here in the chat somewhere. What about prednisone? So you are mixed. I'm mixed. I profess I'm mixed.
I'm mixed as well.
You're mixed. Tell us all. I'll tell you why I'm mixed. I'm mixed because prednisone is not benign, and I'm mixed because of some evidence of prolonged virus shedding. That's the main reason I'm, to be honest, and what that does to somebody. And of course, no evidence in our patient population. But now why are you mixed?
So it showed benefit in the severe disease and when they were on mechanical ventilation. So a lot of our residents, 30%, were asymptomatic. So I would not propose it in an asymptomatic resident due to risk. And then also, exactly. We don't know exactly when that time point is going to be when you catch it entering the inflammatory stage and the virus is no longer replicating. So our laboratory services during our outbreak were pretty limited. So getting an inflammatory panel that I could trend may be a difficult proposition if you're in an outbreak, but I'm interested in your experience.
Yeah, I agree with everything you're saying, and ultimately, I'm more worried about the side effects of delirium and the hyperglycemia and the agitation, the falls potentially associated with all those things, and obviously we can support that when you have limited staff, right? And then you have limited nursing oversight in a facility where there's COVID. Now you're giving them high-risk medications that might make them delirious and agitated and, affect their sleep behaviors. You always have to balance the risk benefit. And so I'm just not convinced that it's been studied in patients, that are as frail as ours early on, right? So most of the literature is.
Yeah, and I think that's kind of where I'm at. I mean, it is routine treatment in the hospitalized patients now, and actually, I have a little bit lower threshold now to send. Actually, I always had a fairly low threshold to send patients to the hospital. So when I feel people are entering the inflammatory stage, and when that oxygen saturation drops, to me, unless they are comfort care, they have no business with me, actually. They should be in the hospital receiving whatever the newest drug is, remdesivir and dexamethasone. I mein, that's what they should be receiving, and they should be very closely monitored. And then as soon as that is over, they can come back to me. But I just feel this is not what I should be treating unless they're comfort care. And maybe in that situation, one could use it, in fact, just to, when you feel like people are going in that pro-inflammatory state, and maybe in that inflammatory storm, maybe that's the time to use it. The thing is, I haven't had any COVID patients lately, so I haven't actually used it. I wonder what anybody else is thinking about that, but it could potentially be a palliative intervention. That's how I'm thinking about it now.
You mean treatment in place, right, as an alternative?
Yes. So if you say, I'm not going in, I'm, I really don't want to be hospitalized, and you see those, that inflammatory storm, and you see the oxygen saturation dropping, maybe that's the place for compassionate and palliative treatment. that we then add the dexamethasone 6 milligrams. Somebody I know does dexamethasone 6 milligram daily for 10 days. On everybody says who's dropping the oxygen saturation, and I'm saying those people should not be with you. So that's sort of the tension that I feel around that.
Well, I'd like to address some of the chat questions here about inhalation and aerosol generating procedures. So, on that note, what I did early was pretty much eliminate anybody on NEBs that we had in the building unless they couldn't tolerate inhalers. And I put many patients on inhalers that had cognitive impairment with nursing assistants. And I have to tell you, I didn't have any COPD exacerbations.
I know. There's another one. Do we really need all those those nebulizers? The many? Probably not, right? That to me was a big thing. That there's maybe one that I still have, but yeah, that was like, wow, this was not needed.
And it's so much easier for the nursing staff to manage, right? You reduce the spread. I mean, it just seems like it makes a lot of sense, and we still continued most of them. So it's interesting.
But so I think most of us have caught on to this. Yeah, we're not using nebulizers, but there remains one problem with one intervention, and that remains a challenge to me and also how I advise my medical directors, and that's CPAP. And CPAP in any patient, and in particular CPAP in COVID patients. How are you approaching that, Ellen?
So a colleague of mine had a patient with COVID-19 asymptomatic, but is on CPAP at baseline for sleep apnea. And they actually transferred that patient to the hospital to find a safe disposition because they had no negative pressure rooms, old facility with shared ventilation. They felt that it was just going to be harmful for the transmission. So the hospital was compassionate and worked through that to find them alternative placement until they were safe to return. So that was really, it was wonderful that they were compassionate and we worked as a team.
Yeah, we didn't have any issues. I think most of the folks we were able to get into a private room, and we just sort of hope for the best kind of thing. And none of the staff got infected, and patients did well. We didn't have too many that had COVID and required CPAP actually. Small sample size.
So we had this situation lately with the CPAP, and I'm interested what you're saying about that. So we had a facility in Utah, in a veterans facility. We think potentially this spread was through the ventilation system. A lot of the facility was affected. So the medical director chose to discontinue CPAP in all of her patients who had CPAP. There weren't that many, but some, which I think, in an emergency situation, that is not necessarily an unreasonable thing to do, especially if you consider that maybe you only need to do that for 10 days. But now she is reintroducing and they are also readmitting. And then the question is, how do you deal with that now? And what we figured out was, so CPAP COVID naive patients will be treated differently than CPAP COVID recovered or COVID experienced patients. So CPAP COVID experienced patients really are, and not longer considered contagious, are actually great to be cohorted together with, if you want to, with CPAP who are COVID naive, because they can't be hurt. So those should probably, if you want to cohort, if you have 2-bedroom rooms, you want to put those patients all together with COVID experienced patients. And then COVID naive patients with CPAP, they should, and they come from the hospital, they should probably be, they should be in single rooms. And then what an infectious disease specialist has recommended, that they remove the transition time is the most important time, and that they remove the CPAP themselves if they can, and then close the door for 30 minutes. That's one way of doing it. But it's not an easy situation, especially as we are finding now. We can't put everyone in single rooms, which is better in assisted living, where you have people in single rooms. But in nursing homes, we can only afford to quarantine so many people. We will run out of space eventually. All right, let's see. People are asking about inhaled steroids. Do you have any opinion on that?
I have not used them for the
No.
purpose of COVID-19. And the same practice, we were DCing, nebulizers. So I guess if it was handheld, sure, they were continued on that at baseline, but no, I can't speak on any experience.
Yeah, I have not used it as a treatment, just as a replacement, with a spacer typically for, those on NEBs.
Yeah, I have not either. I mean, yeah, so I think we'll open question, one of the many open questions. Probably also more a palliative treatment, if anything. But if it's this bad, I'm thinking probably more systemic steroids at that point. What about, let's switch, let me see whether there is any other open questions. So spacers, we're talking about inhalers versus nebulizers. I think spacers have made a big comeback in this situation, and they have been really useful. Some of them cannot hold them and cannot correctly inhale. That's true, but I just haven't seen the bad outcomes that I thought I would see. I thought I'd see a lot more COPD exacerbations, but I just haven't seen it. So maybe these inhalers are not that important. I don't know. So then has this, so let's talk, if we may, let's pivot a little bit to post-COVID treatment. And let's start with a poll to also touch on some regulations. Erin, if you could put now we have a more traditional poll that's up now. And it says, how comfortable are you about stopping transmission-based precautions of your COVID-19 patients using the new CDC time-based guidelines, 10 days and 1 day fever free? And you have 3 options. I'm very comfortable and have changed my facilities policies to this strategy. Second one is 10 days is too short. I'm using a longer time-based strategy, or not using time-based strategy. Continue to utilize a test-based strategy. So feel free to submit your answers. And Erin, when you feel the answers have dropped off, about a minute, we can have a look. So this is interesting. Only a very small minority is still using time-based strategy. So, there was a recent, and 2 weeks ago, we presented this data on, again, not on nursing home patients, but in I think, a more general patient population in Korea, looking at those who have prolonged shedding and not finding any, in a population of over 700, not finding any evidence of COVID transmission, which really kicked off the time-based strategy from CDC. So most people, what I'm hearing, 88% of you are using time-based strategy. And I was a big test-based strategy person, and I actually have changed myself, because what you're saying, Ellen, the prolonged severe isolation for patients is just been very hard. Plus, there's the whole issue of PPE usage. I mean, it has a lot of consequences. It's not just, oh yeah, let's just leave them there. There's a lot of PPE that's used. There's a lot of isolation going on, and it has other consequences that are not necessarily benign. But whether you're using, are you using 10 days or using something else?
I don't have any COVID positive patients, but based on this, my strategy would be, again, see them at that 10-day mark, review that fever and the other symptoms, review comorbidities, and say, I do not believe this resident is severely compromised. I do not believe they have severe disease. Therefore, I believe 10 days is appropriate versus the 20 days, which would be for our more severe cases with immunosuppression.
I think it's a very reasonable strategy. And I like the fact that you take that opportunity to re-look at the patient at 10 days. And even as a medical director, maybe write a little note. I have reviewed this patient and I'm making a decision based on what I see. I like that. How about you, Stephen?
Yeah, I honestly have different protocols in different buildings. I think part of it, part of it has to do with the geographical infiltration, right, of the prevalence of COVID, which buildings had outbreaks, which ones didn't, which ones have access to PPE, which ones don't, which ones have access to testing, and which ones still don't. So two of my facilities are hospital-based, and so testing is readily available. And we actually continue to test on day 5 and day 11 after admission. So we typically still isolate them for 14 days. And again, a lot of this is also state regulation dependent. So we have to make sure we're making all the parents happy, federal and state. And then, if we have tests available, we just want to offer it. And I think we haven't actually caught anybody that's come in after being tested from the hospital with this strategy, but we feel that, we feel more comfortable. And it provides reassurance to the staff as well that the patient that's going upstairs for an extended rehab has 2 negative tests in the facility within that time frame. In facilities where we don't have a lot of prevalence, we try to test once on day 5, and then we typically don't test again. And in some buildings, we really don't test at all. We just keep them, for 14 days if they've been exposed or have come from the hospital. So, in any of those settings, we haven't caught anybody that has come in having had 1 negative test in a very variable time frame in the acute setting that has then converted to COVID positive afterwards. But the prevalence in Western New York has subsided. So that has something to do with that, I'm sure, as well. So it's kind of variable, and it's interesting. I'm trying to wrap my head around, well, what's the best strategy? And I have different ones in different buildings, and they're all working. So it's like, well.
I think it is really difficult because that 14 days quarantine is tough on patients. It's tough in their rehab stay. It's tough on PPE reserves. It's a tough thing. And frankly, I have seen it. I have seen a case once where the patient came in, had been tested in the hospital, but not within 48 hours. So I don't know what your hospitals do, but we in Seattle are successful in asking hospitals to do a test within 48 hours, even if a prior test was negative. This patient didn't have that test, and she turned positive 4 days into the stay, didn't infect anyone, although she wasn't in quarantine. And but that's the only case I had among many. I don't know about you. Have you seen? You probably haven't seen that either. So I think the anxiety around that is still pretty high. But in effect, I'd love to see some data. Probably very little. Our biggest problem is the staff coming in and coming in and having partied, or they're their son has partied. I think that's really, or they live in crowded conditions. You know, many of them are minorities, and minorities are at higher risk for living in crowded conditions and not having access to social distancing. They just can't afford it. So that's really where we get all our COVID from, is mediated through staff. But there is a lot of anxiety from the hospital, and it would be good to see some data so we can maybe relax on that a little bit.
I'd like to share one other thing, and this stems from also one of the questions in the chat. You know, are we testing all the residents if a patient does turn positive? I think what we're finding is that if a staff member tests positive, which has been more common, we're still getting about 1% of our staff testing positive every week across the board.
Oh, really?
Yeah, and we're testing every week in New York, so everybody's, all the staff are testing. What we're finding is that if we're putting that unit that the staff member worked on, or several, if they've worked on several, on precautions, we do it for 14 days still, again with New York regs, and none of the patients are getting sick. So, if a patient develops symptoms on that unit, we will test them just to see, because they're the most likely, but all have been negative so far. So ultimately, just putting the whole unit on precautions seems to be working. And as long as the staff that are working are wearing their masks and such, we haven't seen anybody transfer it since we do have access to PPE.
Yeah, I have other experience. So I have the experience when there is a positive resident, and then you test the entire units, picking up a few more positive residents, and then you test the entire staff, and then you pick up, oh, okay, there's where they come from. And I've had a recent outbreak where also the source of the infection was staff to staff. A lot of that, I think there is a sort of a fatigue and staff when they are together. And that's something I think that is something that I didn't realize in the beginning, speaking of how important that staff to staff transmission is. In the facility, actually, people sitting in these windowless rooms and they want to have their mask off. They're not doing social distancing. I apologize about my dogs. Not doing the social distancing when they eat. Those are very high risk behaviors, and they actually have led to some outbreaks. So I think that's something I didn't realize in the beginning, and that's something that I'm really trying to continue to enforce. So my opinion on this, Jai Kumar, is test. We have testing available now. We have that available now. I would test the whole floor, both residents and staff, and I do it quickly. So not everybody has maybe that testing available, but I think now that we have it available, that is the way to stomp down an outbreak before it gets out of hand.
So Sabine, you're talking about a situation where a patient tests positive, right? And I think what I was referring to is a staff member testing positive without any patients tested or testing positive or having symptoms. So those are like kind of two different scenarios potentially, right? So if you have a staff member that tests positive, are you then testing the entire patient cohort?
Yeah, I have had some staff test positive recently, and we test their close contacts, their patient assignment. So it may not be the whole wing, or it may be the whole wing. Just depends on their position. But we will test their assignment.
And have you found anybody turn positive?
No. Thankfully, our PPE supply is so much better than it was in March. And then also our mask wearing and our hand hygiene, I think, has improved because we've experienced the outcomes, we've experienced the outbreak. So I think that, we in Indiana are only testing staff via the state once a month. So we did it in June, not in July. We're going to test again in August. And then it is going to be more frequent, hopefully, to get to the weekly testing like New York. So, when we pick up those cases, then we do some contact tracing. And we have not seen it transmitted from these staff who are asymptomatic. Hopefully due to that mask wearing.
this is interesting. So you do weekly staff testing now, point prevalence staff testing. How about in Indiana? Are you doing that?
We do it once a month with the goal, which just started in June. So we skipped July, getting ready to test again in August. And then our goal is to get to weekly like New York.
I think that is a very good strategy. Who pays for that in Indiana?
The State Department.
Nice. And in New York?
The facility.
That's a high bill.
It's about $100,000 a week in some of my facilities.
Yeah, yeah, and not every facility can afford that. Yeah, so we're looking at this in the state of Washington. We're looking at regular cadence testing. We haven't gotten a recommendation yet. Supposedly it is forthcoming. Here's a good question. Which mask are you emphasizing, surgical, N95 or KN95? Good question. I've changed my mind on that too. Start us out, Stephen. What do you think?
Yeah, we're really just wearing regular surgical face masks. It's pretty rare that anybody's wearing N95s. Again, in facilities where we do not have outbreaks, during outbreaks we give it to the nursing staff. We have them available, but I got to tell you, we haven't seen any staff contracted even just wearing face masks in my experience.
How about you, Ellen?
Yes, surgical mask is what we are emphasizing. I do see that the facility has KN95s that they are giving to staff as the supply allows. When we were in the peak of our outbreak, the staff were given N95s.
Yeah, so I think we're all kind of in agreement. If there's no outbreak, just surgical masks are probably a good strategy. And when there is an outbreak, give them whatever you have. That is better probably. N95 or KN95, my understanding is KN95 is not as protective as N95, and that leads to the next thing. Do you guys do fit testing in your facilities? No? Yes? So we are doing fit testing, but then the question is, what about that dome? And, what if somebody is positive? And how do you sanitize that? Have you found any intelligent approaches to that other than just rub it down?
Yeah, in my hospital-based facilities, we had everybody fit tested in the beginning, but then as supplies ran out and we had different manufacturing types of N95s, we really had no ability to fit test for them. And so we kind of just gave up on it, and we just said, hey, this is better than a surgical mask.
Exactly. And I think that's the kind of emergency type of thing that I would like to go away in a way. But that's still a reality. You give them what you have, and you do the N90. You save the N95s for the outbreaks. But what I used to do, and what I really try not to do anymore, that was we used to reuse N95 and had them clean. Mm-hmm. And there's evidence that the efficacy of that N95 will decrease significantly. So reusing N95, probably not a good idea, even if they are clean. They just don't have that same fit anymore. So I think that's one that I think where the opinions are probably pretty firm at this point. Would you agree with that?
Yeah, definitely.
Has anybody heard of OSHA finding those who are not fit tested? I haven't.
I have not.
Although I have just heard of a survey citation around that. So, so that's that I have heard. And yeah, the whole fit testing in the nursing homes is not well. I think that's still a opportunity for us to improve. The other question that somebody asked, and I think that's a really good question, Can rehab admissions from the hospital on 14-day quarantine be allowed to walk in the hallway with a surgical mask? What do you think?
Yeah, we don't. We try to stick to the 14-day plan for now, and then once they're off of it, then obviously they're transitioned to a different wing of the rehab unit, and ultimately, at that point, they're encouraged to wear masks, but they're not expected to.
How about you, Ellen? It's such a hard and heartbreaking situation in a way,
Mm-hmm.
right? I mean,
Right.
I feel inclined to allow it, but
Mm-hmm.
but I also am chicken to allow it.
Well, we encourage and treat in their rooms,
Yes.
but we have had some dementia residents wandering, and so when we can't redirect them, we just allow them to wander safely. So it does happen, and we do try to encourage wearing the mask when they are doing that.
So I think we all had the demented patients that, just to try to give them a mask and do the as often as possible hand hygiene, and just try to do your best in this setting. Yeah, I would love to see some data on the whole quarantine issue, and how long do you really need to quarantine. And at this point, it's really it's an incubation time cycle really at this point that we know of. But yeah, we don't walk people in the hallway. But maybe we should, or maybe we should in certain times, and maybe we need to be a little bit more innovative around that. I think that is a sad state of affairs for somebody who comes to the hospital to be in rehab. Yeah. Another question. Of people actually still in the COVID illness situation. What do we know about anticoagulation at this point, and what is it that you're recommending? And Ellen, I know you don't see COVID patients right now, and I haven't seen one for a while either. What about you, Stephen?
I'm still mixed on that one, honestly. I think, looking into the data, it appears that, putting somebody on prophylactic dose probably, I would say, is low risk, though I would be concerned about full dose anticoagulation. I think the jury's still out on that one. We've seen significant hemorrhaging in patients, life-threatening hemorrhaging, on anticoagulation, and you sort of wonder what stage of inflammation they're at, when you're starting anticoagulation. So I honestly feel a little bit in the dark about the strategy. It's like, yes, they're hypercoagulable, and yes, they're really sick, but is that true and unrelated? Right? Are they hypercoagulable because they're in DIC because now they're at the end stage of COVID infection versus somebody that's early, with early onset? It's hard to say.
Yeah, so I've seen pretty different strategies. You could use aspirin. Some people use aspirin. Some people use enoxaparin for 2 weeks. I mean, there's different strategies, and I think it's always and I think we are in the dark. But what Richard Pfeiffer said in this actually grant rounds a few weeks ago, he said we should think about it. I think that we may make different decisions with different patients, but it should be, when we treat patients, we should think about it. Like we should think about their oxygenation. We should think about their anticoagulation status. So I think at this point, the jury, that's another one. The jury is still out. We do know it's a risk, but the jury is still out. So last but not least, question, post-COVID syndrome. What have you observed? And especially in your patients, Ellen, you've had a lot of COVID patients. What have you observed? How have you approached it? So we know that patients a large amount of patients have post-COVID fatigue, shortness of breath, chest pain. And the study last week showed perimyocarditis in a large amount of patients. So this is not a one and done. This is more like, some people say, this is more like mono, probably a little worse than mono. So how have we approached that?
Well, I think all the things that Steve was mentioning, aggressive supportive care, because I have seen fatigue and hypoactive delirium. And a lot of residents with dementia who seem to be on their final decline after COVID. They have not recovered their baseline, and they haven't recovered their baseline quality of life. So we are doing, aggressive supportive care with nutrition. We're working on their mobility and deprescribing, like Steve mentioned, of course, deprescribing. And then we are having really transparent advanced care planning discussions with families because there's a lot of uncertainty about the post-COVID syndrome and how it will play out. And so we have to just be transparent that we don't have all the answers. This is what we think, we're dealing with. And so just continuing those advanced care planning discussions is where I'm at.
Yes, I like that approach that you inform people, and I inform my patients now, and I say, that's part of it, is those that are not demented. I say, they say, I'm so fatigued. I said, yes, this is probably due. I just had that conversation yesterday. So let's do everything we possibly can to have you eat well and tolerate. And so we worked on strategies to tolerate more PT. We have no outcome measures on that, but certainly evaluating patients once they come off the COVID disease for, I love the aggressive supportive care and also for rehabilitative strategies. Have I put anybody now on anything anti-inflammatory since I saw that article? No, I have no idea what that really does. I will tell you though that I am now watching for CHF, no onset CHF, as a possibility, although the article didn't say, there was a statistically but very small change in ejection fraction, I think 3%, but not not clinically significant. But this is something that one would want to watch for in patients now. How about you, Stephen? Do you have anything to add to that?
Sure. So, I'm a big frailty believer. And so, we actually measure frailty routinely in all our patients. And what we're finding is that there's a subset of patients that I think if you get too early and you support them, you can pretty much get them to their baseline after a successful COVID, illness. But the ones that don't do well typically, basically get to a lower degree of functional status, cognitive status, and so they become more frail. And so one of the things that, I'm actually studying are the clinical characteristics of patients before they get COVID, and then looking at how they compare on a national level to those that do get COVID. And to no surprise, they're disproportionately the most frail patients in a facility. So that's really interesting. And I think, the expectation is that they're going to be at a lower level of function generally post-infection. One patient, I ended up actually having very aggressive treatment with IVs until about 3 weeks after they were infected. So they survived 3 weeks, couldn't get them to eat. And we had to have a peg placed, and there was a lot of discussion with the family. They reversed the most from comfort care to full code, at which point we had to send them to the hospital, and they had the same issue, and they put a peg in him, and he survived. And now the peg's out about 2 months later, and he was demented before, but he's pretty much at his baseline, and it's kind of surprising that maybe pegs are the treatment for COVID. I don't know. But it was not a recommendation. And, they did well, and without really, drastic differences, despite all that. So it's kind of interesting. I think we're seeing.
It is interesting. So maybe there is that So the German study put on the MRI said was from day 60 to day 92, and they called it the early post-COVID recovery period. And I'm thinking 3 months, is that really early? But maybe we just need to give it, maybe we can be optimistic and give it a little bit more time. Of course, this is, again, an N of 1. So I don't know that I'm inclined to stick feeding tubes into my frail old patients, but it is a thought that we don't know how long this lasts. Maybe it is really like Mona, at some point even mono is over, right? And so maybe this post-COVID syndrome is also over at some point. I have a question for you though. You said, if we get them early enough, what evidence do you have around what is early, or do you have any data yet that can tell us, you know, if you get them at that point, and what frailty index are you using?
Yeah, so early, you know, in my experience, is really there's an outbreak in the building, right? So you know you have COVID, and treating, you know, those particular patients that are on the unit or in the facility, depending on the level of the outbreak, with aggressive supportive care early. We've seen, you know, significant differences in units where you had dedicated, truly dedicated nursing staff that were there pushing fluids, giving them ice cream, whatever they could get into them. And they did remarkably well compared to those that didn't have that level of nursing dedication for staffing reasons.
Interesting.
Or, you know, even in the same facility where we had a lot of outbreaks. So that's just been, you know, my experience. I think if you wait until, you know, they're in full blown, you know, hypoxemia or sepsis, I think you're probably going to cause a hospitalization and have high risk for mortality. I use the frailty index that I use is one that I modified from the Rockwood frailty index. So it's, you know, internationally used actually in pretty much, you know, every country except the US.
Can you send us maybe a link to that so we can put it together on the website for us to use? Because that might be a good idea for us to, all of us, to look at frailty before and after. There's this interesting side conversation going on here with the hypoglycemia, and I think that just speaks to the fact that patients, and if they're diabetic, they're just only, you know, when they have COVID, and that may be a real issue. So we are at the top of the hour, and I really want to thank you. This was ended up being a very interesting discussion for us, and I think I thank the audience for the lively participation that makes it such a much richer discussion for us. So I have learned actually quite a bit. So I think the one take-home thing that I guess I knew, but I loved it the way we all verbalized it, is that aggressive supportive therapy. Aggressive supportive therapy during COVID may have dividends, may give you a better outcome moving forward. And however you can do that, some people can do it with ice cream and hydration, and others may have to resort to crisis or whatever it is. Aggressive supportive therapy probably works. Prednisone, we feel, I think all, that there is no role in the nursing home for that we know of yet, unless it's for palliation. Anybody who's sick enough to use prednisone should probably be in the hospital setting. And there is a lot that we still don't know, like how to best anticoagulate, or if we should anticoagulate. We only know that we should be thinking about it, but what we need to do, we don't really know. We are so much better off with with the testing that is available to us now, and hopefully many states will be able to have weekly testing, mainly of staff. I think that will be a big step forward for all of us to keep those outbreaks at bay. So with that, I invite you to join us for our next COVID Grand Rounds in 2 weeks on August 20th. COVID-19 did shine a spotlight on social determinants of health and race-based inequities, even in our space. We will be discussing how this was evidenced in our communities and facilities and what our responsibilities and opportunities are moving forward. Please join us for that important discussion. Until then, again, thank you, be well, and thank you all for the good work you are doing on behalf of those who really need it. Be well, bye-bye.
Thanks, Cindy.